So thank you all for joining today's Pediatric Clinical Pharmacology lecture series. I am super excited about this topic, and it really gives me great pleasure to introduce our speaker for today, Dr. Melanie Cree. Dr. Cree is a physician scientist, pediatric endocrinologist, and professor at the University of Colorado, Anschutz, and Children's Hospital Colorado. Dr. Cree founded and directs the Children's Hospital Colorado Multi-disciplinary PCOS clinic, has published on this clinic model, and guided the creation of similar clinics at multiple centers within the United States. Dr. Cree's research program is focused on improving care for women with PCOS. Dr. Cree directs a 21-site collaborative to document the natural history and effective current therapies for adolescents with PCOS. She is working with the Centers of Disease Control and PCOS Challenge to standardize testosterone assay ranges for women. Dr. Cree's translational research program focuses on disorders of insulin resistance that affect the reproductive axis and cardiometabolic health. She recently completed 2 clinical trials to treat steatotic liver disease in girls with PCOS with an amino acid supplement and 4 months of oral semaglutide. She is currently conducting an NIH-funded clinical trial to assess the effect of injectable semaglutide on the rates of ovulation in females with PCOS and obesity. Dr. Cree is dedicated to professional education and mentorship in women's health, giving presentations across the globe and mentoring at all levels of trainee. She is a leader within professional organizations. She funded and was a former chair of the Pediatric Endocrine Society PCOS Special Interest Group, and is currently a board member for the Androgen Excess PCOS Society. Dr. Cree regularly works with patient organizations, primarily PCOS Challenge. So please join me in welcoming Dr. Cree.
Thank you, everybody. I'm excited to be here. So you're going to hear a lot about those trials that were just mentioned. And we were just discussing, I'm in revisions for many of the data that I will be presenting today. So hopefully we'll have this published soon. I do have some conflicts. I consult for both Eli Lilly and Novo Nordisk, so sit on in an equal spot for both of those medications. I'm a speaker for Kaiser Pharmaceuticals. Abbott Laboratories donated continuous glucose monitors for my current trial. And then I'm a site PI for AminoCo, Eli Lilly, and Rhythm Pharmaceuticals. Everything that I discussed today will be off-label. There are no FDA-approved medications for PCOS, and in fact, there is no clear pathway for medication to be approved for a PCOS indication within the FDA. So what is PCOS? It's defined by menstrual cycle irregularities, elevated testosterone or signs of elevated testosterone, such as growing a beard or severe acne, and polycystic ovaries, which we only measure in adults because we don't know what teenage ovary norms are. What we hear about most is the infertility. Many women present for infertility. And then once these women do get pregnant, there's higher rates of miscarriage, gestational diabetes, small and large infants. And these women are also at higher risk for endometrial cancer. The metabolic features that we most often hear about are related to obesity, greatly increased risk of type 2 diabetes, metabolic associated steatotic liver disease, hypertension, hyperlipidemia, and sleep apnea. But these women obviously experience really significant cosmetic issues with the hirsutism, acne, male pattern balding, acanthosis nigricans, that's dark skin on the back of the neck or armpits, hidradenitis suppurata. Those are actually, they look like a boil, and they appear under the breasts, in the axilla, and at the groin. And then confluent and reticulated papillomatosis. So these are dark skin spots, but in a leopard pattern. There's also significant mental health struggles in women who have this syndrome, including anxiety, depression, sexual dysfunction, high rates of disordered eating, and a low quality of life. So really, while it sounds like it's just about the ovaries, it encompasses all aspects of these individuals' lives. So how do we diagnose it? The first diagnosis is irregular cycles and clinical hyperandrogenism with no other cause of irregular cycles. This is equivalent to the 1990 NIH criteria. But what has been defined within the international guidelines is what is an irregular menstrual cycle. So in the first year after menarche, anything goes. But at 1 to 3 years post-menarche, cycles that are less than 21 or greater than 45 days are considered abnormal. And if they have one cycle greater than 90 days, then that is considered abnormal. If they have not had a period by the age of 15, or they've had breasts for at least 3 years and haven't had a period, and then after they've been menstruating for greater 3 years until perimenopause, normal is considered 21 to 35 days, which is approximately 8 cycles a year. Step 2 is if there's no clinical signs of hyperandrogenism, then you can test for biochemical hyperandrogenism. This is really currently quite difficult, hence our CDC project. And then step 3 is equivalent to the Rotterdam criteria, which were released in 1996. And this adds ovary ultrasound to the diagnosis. So if they only have one of the two, so irregular cycles or hyperandrogenism, in adults, you can then do an ultrasound, and new for the 2023 guidelines, an AMH, anti-Mullerian hormone. In teens, if they have one or the other, you can consider them at risk for PCO, but you can't make a diagnosis at that time. And the AMH was added for low resource areas. These are international guidelines. If you have access to an ultrasound, you should not use AMH as a replacement. So how does PCOS work? So we think that there's really two conditions that we're calling PCOS, maybe three. The primary two were metabolic and reproductive. So reproductive, we think, is a primary problem within the GnRH neuron, and that there's excess LH signaling. And LH within the ovary causes the release of testosterone. And it's the excess testosterone that leads to the problems with menses infection and the weight gain. The metabolic part is related to insulin. And so, especially with our modern diet, lots of carbohydrates, liquid calories, we're ingesting a lot of sugar, which creates excess insulin secretion. And in some individuals, this insulin is stimulating the thecal cells to also release testosterone. And if individuals aren't exercising, that causes insulin resistance. So the insulin doesn't work as well. You need to make more. Or if you have a family history of type 2 diabetes. And so the primary treatment recommendation for PCOS in individuals of any body size is lifestyle therapy. And the reason that we do that is it decreases insulin. And decreasing insulin in many individuals with PCOS will decrease the testosterone and help with their symptoms. So the carbohydrates, so decreasing carbohydrates, cutting out all liquid calories, moving first before we start talking about exercise. Many people aren't even moving enough. And this works in a fair amount of women. So why do we care about PCOS, and when should we care about PCOS? It goes across the lifespan, and in children, we can see premature adrenarche, so that is early hirsutism, and then in boys and girls whose mothers have PCOS, we see evidence of insulin resistance and increased cardiovascular risk markers by the age of 7. And then in adolescence, you've got hirsutism and then acne, but it's really hard to assess acne in a teenager because of the effects of puberty. You start seeing oligo-ovulation. And so let me just go through this really quick for you. So white is none, light green is in some, the peak is the bright green. And then if it's different from an additive life stage, so here puberty. And then if I put stripes through it, it's even worse when the patient is experiencing obesity. And so you can see that basically everything is going on in adolescence, with the exception of sexual dysfunction and infertility. And then when women have really established their reproductive patterns, so this is going to be 3 years post-menarche, all the way through perimenopause, women experience all of these symptoms. And the only thing that changes post-menopause is the decrease in acne, and then obviously not having issues with infertility. And at this age, we're now seeing your cardiovascular endpoints, so stroke, heart attack, and increased mortality in women with PCOS or with a history of PCOS. This is some really cool data that was published this year. So this is out of a group at Harvard. And apparently Apple has a research program that you can apply to, and you can do a clinical trial through Apple. And so they're doing a clinical trial tied to women's Apple Watches. So they have to have an Apple Watch, own an iPhone, live in the United States, and be greater than 18 years. And they consent to have all of their data collected and followed, and then from the health app, and then they fill out surveys on a regular basis. And so far, they've collected data from 50,000 women, and approximately 12.6% had PCOS that had been told to them by a diagnosis. And then they estimated that 17.4% had PCOS based on symptom reporting. And so what I've got here is the average BMI by age category. And the red, you can see across the top, has the highest BMI at any age group, with the average BMI at age 18, 26, which is in your overweight range. And then your BMI by the age of 25 is obese. So the average BMI of women with PCOS is obese from the age of 25 on. Is this a biased sample? I'm sure women who are trying to lose weight are more likely to buy an Apple Watch. But it's really the first time we've had this population level data from the United States. So what does it look like in our teenagers? And this data is from a NICHD R21, and we are in the process of writing all of these manuscripts. So it's 20 sites across the US. Retrospective, we've got data from 120 girls with NIH type PCOS. Per patient preference, WOO is without obesity or overweight. We can't call them healthy. We can't call them normal, because that is assuming that people in a larger body size are not healthy and not normal. Hence the name and the acronym. So what I've highlighted here is the metabolic complications per weight category. And two things to pay attention to. One, in those without obesity or overweight, and that is the first column on the left, 14% had prediabetes, and 7% had a triglyceride greater than 150. 31% had a low HDL. 26% had an elevated ALT as an indication of liver inflammation. 12% had a low sex hormone binding globulin as a reflection of insulin resistance, and 6% had hypertension. So even in people in a smaller body, we have to pay attention to this in PCO. Now, when you go to our larger girls, 26% had prediabetes, 38% had elevated triglycerides, 84% had a low HDL, and 60% had an elevated ALT. So this is why, I really pay attention to this patient population, because they're in trouble. So this was some data trying to understand kind of what at the pathophysiologic level happens with is happening in teens with PCOS. And this is girls with and without obesity and with and without PCOS. And this was actually funded by Office of Women's Health Research, Birch Grant, and then an NIH NIDDK T32. And so what we found doing these really intensive metabolic studies is that these girls with PCOS, regardless of body size, have decreased adipose liver and muscle insulin sensitivity, decreased muscle mitochondrial function in the setting of exercise, increased liver fat, increased carotid intermedial thickness, but no real change in body fat muscle percent, and interestingly, no change in resting metabolic rate, despite the fact that it's easier for these women to gain weight. And so this data is important because this gives us some targets and some things to think about as we're trying to move forward. And we also found that the liver fat really related to excess production of liver fat, so hepatic de novo lipogenesis. So then for my K23, I wanted to figure out, well, when and where can we treat girls and how can we look at what outcomes should we use for interventional trials? And you really see dysglycemia and then metabolic changes related to the formation of liver fat in the postprandial period. So I moved away from the gold standard of hyperinsulinemic euglycemic clamps and did these extended oral glucose tolerance tests and worked with a mathematician at Colorado School of Mines. We adapted all of these measures of insulin resistance in adults to be appropriate for kids. And so here I'm showing untreated PCOS versus girls the same body size, but with regular periods. And diabetes was excluded from this study. So the girls with PCOS have higher glucoses, especially around the 120 and 150 time point. They've got this really abnormal insulin secretion pattern where the insulin comes up in the beginning, but then we think in response to the continued elevated glucose, have this second phase insulin peak. They had lower GLP-1 concentrations initially than the control. So we think that second phase insulin peak is actually due to inadequate first phase secretion. And then they had less glucagon, and that should have gone up when the insulin went up. So what are our treatment options? So we've already talked about lower sugar foods, physical activity. Other components of lifestyle that are really important is to treat obstructive sleep apnea and also to ensure good sleep timing. And I've done a lot of work with sleep colleagues to demonstrate that this really matters in our girls with PCOS. And then metformin. So we keep talking about high insulin, secondary to insulin not working, insulin resistance. So metformin works by increasing insulin sensitivity. And then what about, I want to treat my hair. I want my beard to go away. I want my periods to be normal now. Metformin works in about 60% of women. We think maybe that's that metabolic phenotype. But the primary recommended therapy is an estrogen-progesterone combination. In the guidelines, it says pill because that's available around the world. Within the United States, we also have access to combined contraceptive patches and rings. So we're going through our teenage data right now to figure out the effect of these within our Calico database. We don't have any good data in teens. But this was actually a randomized trial that was published this year. And they looked at women with a BMI of 25 to 48 and hyperandrogenic. Rotterdam means everybody at least had an elevated testosterone. And so their primary outcomes were, what is the prevalence of metabolic syndrome at 24 weeks? Birth control pills increase all hepatically produced proteins. That's why you see an increase in stroke. You see an increase in HDL, which is good. You see an increase in sex hormone binding globulin. So more of your testosterone is bound up. That's good. You also see an increase in hemoglobin A1C and an increase in serum triglycerides, which are not what we want in women with PCO. So this was just a really nicely done study. Anuja Dokras and Steve LeGros. And really what they found is that all three trials improved the total testosterone, sex hormone binding globulin, and free testosterone. And all of these women were overweight or obese. So that really comes down to there is this role of insulin. But the two birth control groups really had a change in their ovarian function. So their AMH was decreased because they had lower follicles and a smaller ovary. And I think not surprisingly, we see that the birth control had a higher blood pressure, had higher triglycerides, had a lower HDL. So really what we would expect, but not as bad as we thought. These are just the medications that we use in PCOS to protect the endometrium. There's an 8-fold risk of endometrial cancer. So just so that you're aware of what we often use, and again, in the United States, we've got 2 different rings. We've got multiple different kinds of patches. We have to be careful. Patches are not effective for contraception greater than 200 pounds. If you're taking a GLP-1 and you are using a birth control pill, it is not as well absorbed. So individuals on GLP-1s really are better off with a ring or a patch. And we use topiramate for weight loss, which can interfere with the functioning of the estrogen progesterone combined contraception. The bottom are all progesterones. They don't do anything for testosterone, lowering testosterone, improving metabolic disease, and in fact may worsen it. However, they do protect against endometrial cancer. So you'll see these used from time to time. So what about treatment of MASLD in PCOS? It's been greater than 2 years, so I don't formally have to say that this is a conflict, but I was a site PI for this trial greater than 2 years ago. So this is the first trial of a drug, not the first, but one of the first trials of a drug specifically for women with PCOS. And it's with seroglitazar. It's a PPAR alpha gamma. And the gamma is not surprising. The thioglytazones are very effective for PCOS. We just had all of those problems with the long-term cardiovascular risk with that medication class. And so, we don't use them, but it's not surprising to see that they're going for a combination alpha gamma. And the primary outcome was hepatic fat, and the results were significant. They were presented at the Endocrine Society and the AASLD, and this manuscript is in preparation. They also found the ALT decreased, LDL decreased, as did triglyceride, but no changes in reproductive outcomes. But I put the star on there because everybody had to be on 2 forms of contraception, one of them being hormonal. And so this was one of my problems with this trial from the get-go, is I didn't feel that they should collect or present data on reproductive outcomes, because it really doesn't say anything if you've got people on contraception and they're not on the same kind of contraception. But no significant adverse events. You'll hear in the lay literature tons about inositol for PCOS. There was a really nice meta-analysis done in 2024. There was only 1 adolescent and no data from the United States. And the conclusion was the data to recommend the use of inositol in PCOS is limited and inconclusive. And it's thought that this is an insulin sensitizer as well. So potentially similar to metformin. And so they did do head-to-head comparisons with metformin, and metformin is superior. Rick LeGros is also doing this NIH-funded trial, and they finished enrollment just this last December. So I'll be curious to see what they find out of a well-done RCT, and that is also funded by the NIH. So that's kind of everything else. So what about PCOS and weight? So we think that approximately 20% of women with excess weight have PCO, and 50% of women with PCO have excess weight. And losing 5% of body weight has been shown to decrease insulin and thus decrease testosterone. Now, there are 2 papers in adolescents that prove this, and then 10 papers in adults, mostly focused around improving fertility. But this is what has been demonstrated among these 12 trials, that you have improvements in infertility, pregnancy complications, skin, mood, and sexual dysfunction, as well as improvements in weight-related metabolic conditions. And just as a proof of fact, this is one of the first studies that came out looking at the effect of bariatric surgery in PCO. There's been several more that have confirmed these data, but the starting BMI was 43.6, and then the women had both sleeve and bypass. And by 12 months, almost all of the women are in the overweight category. And with that, you see this really nice increase in sex hormone binding globulin that's suppressed by insulin. So this is an indirect marker of insulin resistance. And it binds free testosterone, so it lowers the bioactive testosterone. So despite the SHBG going up, the total testosterone really came down, which means the bioactive testosterone really came down. And you already saw that at 6 months. And then they looked at the ovary volume, and the cutoff for adults for an abnormal ovary volume is greater than 10. And so you can see by 12 months, the ovary volume in all of these women was lower. So really, proof of concept with no meds, weight really matters. So then what are our appetite suppressant treatment options? So I'll spend some time talking about the GLP-1s. And just as a review, I'm sure most of you know, GLP-1s are stimulated by eating. They're released in the GI tract, and then they are made inactive by the DPP-4 enzyme. And what these do is they go to the beta cell and the alpha cell. So in the beta cell, they increase insulin release. And in the alpha cell, they suppress glucagon release, and glucagon suppresses insulin release. So this is indirectly increasing insulin even more. And so it's been found that these were started for diabetes because they lower blood sugar very well, but then it was discovered that they also decrease appetite to lower weight. So this data is from my K23. So the girls in black now are the untreated PCOS that we saw previously. And then I gave 2 doses of exenatide to these girls. And exenatide, I've put the half-life serum concentration down for you if you're not familiar with this drug. So pretty much 1 dose is cleared within 10 hours. As approved by the FDA for diabetes, it was given twice a day. So they got their first dose prior to dinner. 12 hours later, they got their first dose 30 minutes prior to an oral glucose tolerance test. So this is the direct effect of the GLP-1 with no added contribution of weight loss. So immediately the glucose comes down. You see a higher first phase insulin release. Our assay detected the drug, so that's why GLP-1 is high across, and a much lower glucagon. So in girls with PCOS, the acute effects of a GLP-1 are exactly what has been shown previously, nothing different. So these are data on weight loss medication efficacy. These data come from the primary publications of all of the drug companies. So there is a combined phentermine topiramate. In blue is the data for teens, in yellow is the data for adults. And really what I want you to pay attention to is how many people it doesn't work for. So in adults, phentermine topiramate doesn't work for 33% of people. It doesn't work for 52% of kids. Now, when we get to liraglutide, and this is the higher dose of liraglutide approved for weight loss, it doesn't work for 37% of adults and 57% of kids. And this is that 5% threshold, which is important for PCO, but is also a defining endpoint for all of these companies as well. So injectable semaglutide doesn't work for 14% of adults and didn't work for 24% of kids. Tirzepatide in adults didn't work for 4% in the clinical trials, although there was some interesting real world data presented at the Obesity Society earlier last fall, saying that real world is probably 10% higher than these numbers for each of the drugs described. The weight loss for tirzepatide in kids, the trial is ongoing and almost complete. Retatrutide is not FDA approved for any use right now, but causes absolutely profound weight loss. So you can see 48% of patients lost more than 25% of their body weight. So what about GLP-1s and PCO? So this was the first trial that was done, and it was exenatide plus metformin or metformin, 24 weeks, 60 women. And essentially, the weight loss in the exenatide group is greater than 5%. And what we saw was that the 2-hour glucose, insulin resistance was improved, their sex hormone binding globulin went down, their active androgens went down, and they had more menses. Then there was a randomized trial with liraglutide, and liraglutide is dosed once a day, liraglutide plus metformin or metformin. This trial was only 12 weeks, and so they saw improvements in metabolic outcomes, but really isn't long enough to see a change in reproductive. This one was 26 weeks in women, and this was by the same group. And here they showed a decrease in liver fat. So this is one of the first trials showing a decrease of liver fat in women. And now reproductive and metabolic endpoints went down. So what about semaglutide? The first published data was an in-clinic observational trial, and it was a fertility clinic. So women who failed to lose weight with lifestyle modification received 0.5 milligrams of sema times 3 months. And the average weight loss was 7 kilos. Those who responded with at least 5% weight loss, and so you can see 6 did not, were then given another 3 months. And so of the responders of the initial dose, 78% had normal menses by that time. But remember, 6 of them were cut out because they didn't respond to the drug. And the average weight loss was 14 kilos, 60% of total body weight loss. The first randomized trial with semaglutide was published this last summer. The previous study was in Spain. This study was done in China, and it had women with Rotterdam PCO, so they don't have to have an elevated testosterone. They had 3 years of their menstrual history, and the women were randomized to metformin or semaglutide plus metformin for 16 weeks with no hormonal contraception. And at the top, the weight dropped more in the sema group. The free androgen index went lower, and 73% had increased menses. Whereas in the metformin, they lost 2.3 kilos, but their androgen still went down, and 42% had increased menses. So again, showing metformin can be effective. This next section I put in red, and in my mind, I'm just taking the data out. So there's a couple issues with this. They didn't describe who was offered pregnancy assistance. So is it just that the women in the metformin group, was there a bias where the women in the metformin group offered more assistance in pregnancy? I mean, it's only 24 weeks, that's 6 months. So I think that's a very big problem in the methods that are published. The other problem is that, especially in the United States, you are not recommended to try to conceive within 12 weeks of the last dose of semaglutide. So ethically, this isn't a study that would be allowed to be performed in the United States. They'd have to, have a 3-month washout with metformin only, and then start trying to conceive. So, I'm very comfortable with the results of the first half. I personally find the second half uninterpretable. So then this is my trial data. So this is my first study. And for context, the only GLP-1 approved for use at the time that this study was started, 10 months prior to first participant, at the time that all of the regulatory processes started, was oral semaglutide for type 2 diabetes. And I had to get an FDA IND. And so at that time, we had nothing approved for use in kids. The only pediatric data we had was in liraglutide. So we had to jump from adults to kids, and we had to jump from diabetes to no diabetes. And so injectable semaglutide for weight loss, I think, came out 4 months before study start. And at that point, it would have been too much of a delay to change. So here we are, oral medication. So the first phase was for safety and efficacy data for the IND and the FDA. And then the second phase was 1-to-1 randomization based on BMI and Hispanic ethnicity. And the primary endpoint for this was liver fat. So we consented 60 patients, 5 didn't have PCOS, 18 started in the safety phase because we had to complete 16. 1 got COVID, and the other one had GI side effects and withdrew. And then 37 were randomized. All of the diet individuals completed. And then 2 more semas were removed. One because she thought it was a magic drug and didn't lose any weight because she increased eating junk food. And then 1 didn't take the medication, and we had a threshold for participant removal if they didn't take at least 80% of their medication. They were allowed to finish on 3, and so 1 participant could not get to the 7 milligrams because of GI side effects. So this is the amount of weight lost. So the diet group lost 1.6 kilos, and the sema group lost 5.2 kilos. And 2 girls in the diet group crossed that 5% threshold, whereas 52% of the girls in the sema group crossed that 10% threshold. And remember, this is only 4 months. And but what was interesting is that we saw improvements in total testosterone for both groups and the free androgen excess in both groups. Only the sema group had a change in sex hormone binding globulin and a significant change in free testosterone, but you'll see that the diet group, that there was no difference between those groups. No change in any PCOS symptoms, but it's only 4 months. And hemoglobin A1C went down in the sema group, as you'd expect. It was a diabetes drug. And fasting glucose, trended but wasn't significant. And then the hepatic fat fraction went down significantly. And so then we said, okay, how much of this is weight loss and how much of this is drug? So we took the girls that got drug and divided them by above and below 5%. And the groups were very similar at baseline. 67% of the girls who lost more than 5% had an improvement in menses versus 38% who didn't. And you can see that the change in the free testosterone was significantly better in those who lost more weight, as was the free androgen index. In terms of the metabolic parameters, fasting glucose was better in those who lost more weight, as was the 2-hour glucose, and it really significant, a decrease of 40 milligrams per deciliter at 2 hours. In terms of glucose tolerance, so that's your fasting glucose, there was a difference in the categorical variables, and Matsuda as a measure of insulin sensitivity tended to improve. But the OMMSI, and this is the modeling developed with the K23, was significantly different. Interesting, HDL does interesting things during weight loss, but waist circumference went down, sex hormone binding globulin went up, and triglyceride went down. And now we're not looking at the acute effect of a GLP-1, we're looking at the acute plus chronic effect of weight loss. So here's the glucose in the diet group and then the glucose in the sema group. And you can see after the treatment, the glucose is significantly lower across the entire OGTT. And then when you split them out into the two groups, the decrease in glucose really is related not only to the drug, because you see some effect in those who lost less than 5% of weight, but a much more profound effect in those who lost more weight. And when we look at the insulins, those who did not lose the 5% of weight still look like the acute effect dosing. And one of the big questions that we need to ask in adolescents is using a GLP-1 without weight loss going to lead to an increased risk of type 2 diabetes? This is going to be different than the data in adults, which show that it doesn't, because kids have insulin resistance at puberty. Those who lost more weight, the insulin curve completely came down. So the ovaries are really going to see less insulin. So really the mechanism looks like it's the weight loss effect, with the exception of A1C. So I broke these down by the categories, and you can see the change in free androgen index is very similar between the two groups when you divide them by amount of weight loss, and the same with the increase in menstruation. So this does demonstrate that diet in the presence of very little weight loss is very effective for these girls with PCOS. And then if they can lose more weight, it's even more effective, but it doesn't really matter how you lose the weight on all of the metabolic outcomes, except for hemoglobin A1C. So that is in the process of revisions, hopefully coming out soon. So now this is my NICHD R01. And we are doing a stronger dose. We're doing the injectable semaglutide. And our primary endpoint here is the rate of ovulation. And so once they're screened for the study, we are collecting their urine daily. And what we do is we run a urine progesterone in 1 sample a week for the entire 16 weeks. And then whenever we see a low to a high urinary progesterone, that means that an ovulation has occurred in between, because your progesterone is very low in the follicular phase of the menstrual cycle. And after ovulation, the egg comes out, and essentially the egg sac sits in the ovary and secretes progesterone. And then if you don't get pregnant, then the egg sac involutes, the progesterone drops, and that's what causes a menses. So doing a random serum or a urine progesterone measure can be very sensitive for determining ovulation. And we're enrolling women who are not taking any metformin, and obviously contraception is other than a copper IUD is ruled out for this study. And then we're taking women who are taking metformin. And then we go up to a goal dose of 1.7 per the manufacturer's recommendations. We did not go up to 2.4, which is the highest dose, because in the adult data from the published data from the pharma company, 20% of adults didn't tolerate the highest dose. So I didn't want to have our highest dose be something that at least 20% of the participants weren't going to tolerate. And so we have mid-treatment visits to check for pregnancy and to watch for liver enzymes. And then in the last 4 months, we do their daily urine. We started enrolling November 2023. I've never had such a fast enrollment. It's free semaglutide for 10 months. So the control group is completely enrolled. What we're finding is the women that are on metformin only, they're on metformin only because it fixed their periods. So we're struggling a little bit with that group. As I was doing the end visits, the end of study visits, it became really obvious that some women were having absolutely profound effects, and essentially their PCOS was cured, if you will. So I talked to our DSMB and we talked to an external statistician, and the fact that there's no data in the literature, no trial level data in the literature on semaglutide only. And so it was agreed that we could do an early release of data since there was nothing out there, but not use the primary outcome. And obviously we couldn't include the whole cohort. So what we did is we looked, so we don't have ovulation in here. So we looked at other secondary endpoints related to PCOS only, and we looked at the first 8 participants to lose 10% of their weight. This is also in the process of hopefully being published. So when we look at the women who lose more than 10% of their weight, the average weight decrease is 16.5% of their body weight. And this is approximately a loss of 42 pounds. The typical starting weight is around 200 pounds. The free testosterone went down by 51%. Now you can see one person at 16 weeks and 24 weeks went up. I don't know if we happen to catch them ovulating. We've got blood to run the LH and FSH at a later date. 6 of the women had more menses. 4 of the women went to totally normal monthly menses. 1 woman was the same. She was 3 before and 3 after. And 1 individual had less menses, so went the wrong direction. And so the data on her, not all weight loss is good. So she lost 13.4% of her weight. Her BMI went from 39 to 33, so still technically obese. Her total testosterone went down, great. Her SHBG went up, great. Her free testosterone went down, right? Everything should be fixed. All her markers of PCO were better. And her body thought she was starving. And she actually got kicked into hypothalamic hypogonadism. This is the pattern that you typically see at the other end of the spectrum when individuals are too thin, when they're exercising too much, the female athlete triad. And so I think especially as we're looking at these drugs for fertility indications, we need to be aware that this possibility can exist. If you'd like to hear more about it on FX, the New York Times, it's a silly picture of me, but the New York Times Presents did a special Weight of the World. It was released November a year ago, and it's on 3 patients. One of the patients is one of our teen patients, and she actually did both trials, and so she can comment on that. One of our patients, Grace Hamilton, actually spoke at the NICHD Voice of the Patient this last September. And then this patient below was in the first oral semaglutide trial, and then we continued her on prescription semaglutide. Her total weight loss was 97 pounds. This is a picture of her before and after, and she was interviewed on 60 Minutes Australia. So if you want to hear what the patients say about this, not the data, there you go. So what's coming next? So there's no FDA criteria for approval of a medication for PCOS. The first meeting happened December of 2023, kind of a listening tour, and that was arranged with PCOS Challenge and the FDA. But there are FDA criteria for fertility. So I am aware of at least 3 different companies that are moving forward in this space with randomized trials. And just to let you know, PCOS is getting a new name because women don't have cysts in their ovaries, and it's not about just ovaries. And it should be published in the next 4 to 6 weeks. This medication hasn't worked yet, but I'm hopeful that somebody will pick it back up. And so it's looking at affecting the neurocandy neuron. And a version of a drug for this was approved for menopause for vasomotor symptoms. Phase 1 and 2 studies were very promising in PCOS in terms of decreasing LH and decreasing testosterone, but it had absolutely intolerable mood side effects with the last patient enrollment in 2018, and there's been no movement since then. But hopefully this would be something for the more reproductive phenotype. Oh, sorry. So closing thoughts, we're just starting to get traction on really creating new treatment options specifically for PCOS. I didn't show you any data on phentermine topiramate because there isn't any data on phentermine topiramate. I can tell you my biggest loser on phentermine topiramate is 92 pounds, with Sophie, my other patient, being 97 pounds. And I have great success with it. I want to point this out to you guys. We're really limited in what we can do in terms of NIH research. And the majority of this data is limited to what the drug companies can do. And this is part of the reason there's so little data. So 1 month of sub-Q weight loss semaglutide, injectable, so 1 to 2.4 milligrams. I pay $1,300 a month. My drug costs per patient are $15,000. Patients can get the same dosing for $350 a month. I can't prescribe the medication as part of the trial because this discount program is only for patients with no insurance. And so half my patients have insurance and half don't. And you have to give everybody the medication the same way. I've got 2 other colleagues with GLP-1 studies that are struggling with this. The companies won't donate drug for anything to do with PCOS because they have to be on contraception. And unfortunately, they didn't collect adequate menstrual history data. So all of the previous trials that have been conducted, we can't do PCO trial data on them. So my plea, if you guys have any idea, would be to see if we can get an exception from the drug companies for NIH-funded clinical trial translational trials. I'm right at power with my current costs. I'd love to do more. And with that, I will stop and answer any questions.
Thank you, Dr. Cree. Oh, I'm sorry. I'm just going to pull up my video. Hopefully you can see me. Yes. Thank you much. Thank you so much, Dr. Cree. This was an outstanding and really thought-provoking presentation. This is an area that I know many of us are not familiar with, so I think it provided us with a better understanding of adolescent PCOS and, highlighted some really emerging therapeutic areas or directions. So thank you.
Yeah.
We have a couple of questions in the chat. I don't know if we'll get to them all, but we'll do our best. It seems like the audience is really engaged in your talk and has some follow-up questions.
Yeah.
So our first question in the Q&A box is there an association of PCOS with the use of SSRI in teens?
In the fact, not SSRI causing PCO, but the fact that girls with PCO have higher rates of depression and anxiety. So our pre-COVID data from my clinic showed that 65% of girls with PCO coming to that clinic had depressive symptoms versus 34% of our girls who were the same body size, if not bigger, but coming for type 2 diabetes. And at that time, this was higher than the rate of depression seen in girls with excess body weight and no metabolic complications. So really showing that girls with PCOS had double the rates of depression pre-COVID. Now, I would say post-COVID, 75% of teenage girls are depressed. um, as an endocrinologist, I prescribe SSRIs because I see so much depression in the PCO population, but more so as a treatment for depression.
Wonderful. Thank you so much for that response. The next is quite a lengthy comment, but I just wanted to maybe just get down to the meat and potatoes. Um,
Yeah.
they're really asking about, the genetic affiliation with PCOS, right? Is PCOS genetic? Maybe you can speak to that because they really had questions about, why I guess pharmacogenomics wasn't more prevalent in these studies and studies that they've seen. So
Mm-hmm. So Andrea Denafe published a really nice paper, I think maybe 2021, and it was the first GWAS study in women with PCOS. There are 1,200 genes that may be associated with PCOS. And she has continued to do this work and look through it, and she's done some additional work on some specific genes. So DEN1A seems to be associated perhaps with the reproductive phenotype of PCO. But I think it was, I don't know. You'd have to go back at the paper and look at the data, but it was only abnormal in a fairly small subset of women. So actually, she's got a grant that's going to be reviewed shortly, where we're going to look at expanding this GWAS out, and really trying to get bigger numbers and understand. So for example, in Colorado, we have a Center for Personalized Medicine. We've got GWAS data on thousands of patients. So we're hoping to pull that data. But that's why. It's not simple like CAH, where you just have one gene abnormality. There's 1,200 associated, and really DEN1A is the only one. And I would think of it along the lines of type 2 diabetes.
wonderful. Dr. Cree, again, I'm not familiar with this area, but I'm it got me thinking about maybe like the longitudinal effects of semaglutide in adolescents, and do you think that there'll be more studies looking at kind of like how it affects puberty and how it affects these changes later? I know as particularly females move into certain age ranges, they experience different life changes. Do you think that maybe there'll be more studies to evaluate like the longitudinal effects of the semaglutide?
So I think, I can't remember. I mean, the drug companies are certainly interested in looking at that. And so they're doing studies of a longer duration with longer observations. The tirzepatide for obesity is nearly done, and I can't remember the duration of follow-up. But the studies that are coming down the line, they're having 2-3 years of follow-up. And if you enroll a 10-year-old, they could go through puberty and see that. One of my partners just got a 7th percentile on her RO1, so we're waiting for counsel to meet. But we found that there were actually brain changes, and we did a pilot of functional MRI in the oral semaglutide trial. And what we found was that the girls who got the oral semaglutide trial had a better connection between their hypothalamus and the limbic system. And you hear a lot from people who take GLP-1s, the food noise is cut. I'm not worried about food. And we actually think that this may be a mechanism for that the hypothalamus is sensing we've got all the calories in, we don't need to eat more. And is it talking to the limbic center and saying, hey, you don't need more calories, you're not hungry. And so, that's our hypothesis. And the adolescent brain is very plastic, the adult isn't. So this study is a trial of a GLP-1 in teens and adults with functional MRI. to see how does their brain change. Does it change more in teens than adults? And then they get withdrawn for 2 months and we do the functional MRI again. And is there any persistence of the functional changes once we stop the GLP-1? And our hypothesis is no, because once you stop these drugs, people regain all the weight.
Right.
But what we don't know, what if you take a GLP-1 through your entire teenage years? What if you've got years on a GLP-1 in an adolescent with this very plastic brain? And then is that permanent?
Right.
We have no idea, but we know it changes the brain.
Right. Dr. Cree, I wish we could keep you longer and ask you more questions and pick your brains, but I think we're right at time. So I just want to thank you for a fantastic presentation and then your
Good.
willingness to be here and speak and support the series. We are super, just really excited to have had you today.
Awesome. Awesome. Well, thanks for the opportunity. Obviously, I love what I do and you guys all make it happen. So
Thank
gratitude
you.
is two
Wonderful.
ways.
Great. So thank you again to our wonderful
All
speaker.
right.
Good luck on all your endeavors that you're pursuing. I know it's a busy season for you, so good luck.
Yes.
Thank you to
Thank
our
you.
audience today for your participation. I'd like to let you know that our next public lecture will be March 11th, titled Effective Aerosol Therapy, presented by Dr. Bruce Rubin of Virginia Commonwealth University. So again, thank you for your time, and thank you to our wonderful speaker. I hope you all have a great rest of your day.